morning, everyone, and welcome to the 9-month progress report. Let me walk you through my PhD thesis called Functionality and Aesthetics in Plastic Surgery. But first, let me talk a bit about my favorite topic, which is myself. I'm a fifth-year medical student and a first-year PhD student. My supervisor is Neven Teixeira, and my SMS is Lorenz Frivalski. My vision is maximize patient health and satisfaction in the field of plastic surgery. And I want to achieve this by identifying and implementing the safest and most effective procedures. For this, we have outlined 2 specific goals. And I'll begin with the first one, which is called comparing the safety and efficacy of different treatments for pathological scars. I'm pretty sure we have all seen scars, and most of us have some scars. They are essentially fibrous tissue that replaces normal skin after injury. And when we think about the healing of wounds, on one end we have regenerative healing, which is healing of the skin without a scar. In the middle we have normal scarring, which is where fibrous tissue replaces some of the skin. And on the other extreme we have pathological scarring, where there is an excess of fibrous tissue. And the importance of this topic lies in the fact that up to 60% of surgery patients can develop pathological scars. The 2 most common types of pathological scars are keloids and hypertrophic scars. And besides just looking quite unseemly, so besides the cosmetic concerns, they can lead to a number of functional symptoms, such as pain and itching. And despite this, we have no consensus on what treatment to use, despite having a large number of different treatments and many studies investigating this. And our aim is to assess which scar treatment leads to the best cosmetic and functional outcome. So our clinical question is, which treatment option is the best for this? We have patients with keloids and hypertrophic scars as our patient population. We are comparing numerous scar treatment modalities, and their outcome would be scar improvement measured by 2 main validated scales for scars. Their hypothesis is that the combination of therapies leads to better results. And if we were to prove this, we could implement this as evidence-based decision-making in scar therapy. Here are my key articles. This is mainly just to illustrate the wide variety of interventions for pathologic scars. And as you can see, all of these are RCTs because we are conducting a network meta-analysis, and all of these use the so-called Vancouver scar scale as the validated scale I've talked about. Here's our flowchart of selection. As you can see, we have over 200 full-text articles, which is a lot, and that in part explains why we are not able to present figures yet, unfortunately, but maybe next time. And my second topic is the treatment, and it's the prevention of postoperative pathological scarring. Because as I've talked to you about this, these scars are very common and they cause a large decrease in the patient's quality of life. And even better would be than treating the scar would be to prevent them altogether, because up to 60% of surgical scars can become abundant and pathologic. And just like the last topic, we have several preventive therapies with no professional consensus on which one of these is the best. Their aim is to assess which scar prevention method leads to the best cosmetic and functional outcome. So our patients are people who underwent surgery, including scar excision, we are going to compare once again as many different prevention therapies as we can. And our outcome is the severity of the surgical scar. And in the case of scar excision, the recurrence of the scars. And once again, we are hypothesizing that certain treatments are superior at preventing pathological scars. Here is our search key. We are still in the beginning phases of this project. And there are no similar registered meta-analyses. Here are my key articles. Once again, these are all RCTs, because again, we are conducting a network meta-analysis in this as well. All of these have the Vancouver scar scale as an outcome, and these are actually all women undergoing breast surgeries, and they are all within patient trials, which means that on one breast, the surgical excision is treated with one of the treatments, and on the other one, they leave it as control. So we have all the patients serving as their own control. So in summary, we have 2 network meta-analyses planned. One of them is about the treatment of keloids and hypertrophic scars, and the other one is about the prevention of postoperative scarring. And I would like to end with a quote by Niccolò Machiavelli, where the willingness is great, the difficulties cannot be great. Thank you all for your attention.
Congrats, that's definitely a quote-unquote big fish project. It's a great topic, I think. So you started to read all these articles.
Yes.
What's your opinion? What's the best for treating and for preventing these scars?
I'm currently more versed in the treatment. For treatment, I would think right now, before the statistical analysis, that the treatment of, so the combination of steroids and laser is the best for the treatment of mainly hypertrophic scars. I would expect the same for keloids, but we will see in a few weeks, hopefully.
Thank you for your presentation. It was really nice to hear. So my question is on top of his. So you said that this would be the best treatment, and what's the overall success rate of this?
I mean, we measure the decrease of the, so the way we selected the articles is we need the articles to publish the before results of the scars on the Vancouver scar scale and the after results. And then we look at the decrease of that. And just off the top of my head, I cannot tell you an exact number for how large a decrease they would cause, but I would estimate it to be around 70%.
And in the case of failures, do they use excision and then try the treatments again, or?
I mean, that is probably up to the doctors themselves, but in the articles we've included, they didn't use excision, because that would be, because we are mostly comparing like injected and topical treatments, so we didn't look at excisions.
Thank you.
Hi, congrats. My question is, do you know of any compounding factors for pathological scarring?
Yes, for example, diabetes and smoking can be like known confounders, and also obviously like previous treatment, or if it's like a recurrent scar, so it happens that they have already cut out, so like excised the scar, and it returns. So that I would imagine those to be.
Thank you. What is this Vancouver score or system, or what is it?
It's like a semi-quantitative scale, so it's like a semi-objective, I would say. It has 4 domains: vascularity, pliability, height, and the pigmentation of the scar. And the maximum score of this can be 13. And in most of these studies, it is assessed by 2 independent physicians. And so they scored these domains and add up the score, and that's how it. So the 13 is the worst possible scar, and 4 is like the best possible. like 0.
Okay, thank you.